so this is really broad, but I kind of just wanted to throw it out there because I think a lot of these terms popped up, and maybe you guys can speak on them. So, and you have a second part of this, but the first question is whether medicalization necessitates pathologization in this context.
And I guess my second part of the question is, like, when you have like this medical diagnosis, where is power located, and then who gets the authority, and what are the problems with that? So if you guys like each want to speak.
I'll start, I guess, and talk a little bit about what we mean by medicalization in a little bit of a historical context, but also in terms of what we're talking about in the current DSM revisions that are happening. As you probably gathered from the documentary that we're talking about here, is the title of this documentary is Diagnosing Difference, GID, Gender Identity Disorder, in the DSM-IV, but we're also on the precipice of entering DSM-V, which currently is slated to be printed in 2013, last I've heard. So, which is to say that we're right now in the midst of this debate about, do we preserve definitions, terminological categories from that previous model, and do we revise, change, or jettison them entirely? So I just want to preface that in case you didn't garner it from the beginning of the documentary. But in terms of what medicalization does, I'll give a little nugget and then throw it over to these two. The nugget I want to give out is the fact that we obviously talk about that medicalization is one of those terms that's problematic when we think about whether to have a term like gender identity disorder or gender dysphoria, its current potential replacement in the DSM. But medicalization is part of that in the way that it talks about pathologization. How are we deeming sick, ill, mad, confused, insane, or what have you, those sort of implications that happen. But historically, one of the things that these terms do, not just in the DSM, but other medical texts as well, is that these types of terms also provide a kind of legitimization as well. So that all of the terms that we tend to have sexually, gender identity-wise, and most of them that we have done in the past 100 years or so, dealing with homosexuality, transgenderism, transsexuality, bisexuality, sadomasochism, a lot of these terms are most coined and collated, if you will, in medical texts. Now that absolutely pathologizes. What it also does is almost reify, create, or reinforce the existence of these texts. And the anecdote I'll give you is such that obviously many of us know as a comparable example the inclusion or exclusion of the term homosexuality in the DSM is maybe problematic thing. I think that will come up more in subsequent questions. But the important thing to think about is that a term that's coined in medicine bears with it the stigma and also the burden of that responsibility of having medicalized an identity. But it's the creation of those terms within a medical discourse that also makes possible the very discourse that allows us to talk about and identify these identities. So in this place we're in between DSM-IV and DSM-V about whether to keep gender identity in or disorder in or whether to have gender dysphoria, the medicalization is part of the problem that we're talking about. But the other part is the fact is how much does having those terms and actually create a space for existence, if you will, of these identities. Now that does not suggest that the sole place for existence for transgender persons or queer persons of any variety needs to be in a diagnostic sort of text, if you will. But that burden of medicalization has its counterpart also too, which is to say, if these terms helped coin and create the terms we work with, how dangerous is it also to want to get rid of them entirely? So I'll pass it to you guys to take it from there. You want to go?
Maybe I'll just approach this a little bit differently and just give out some information about what's happening. And especially from my perspective in public health. There are now trans folks who are professional, either in the psych field or in the medical field, who are also involved in this politics of diagnosis that's going on. In fact, so the standards of care that they were talking about, the Harry Benjamin standards of care, which are now WPATH, were just released yesterday if you're interested in version 7. And there is a relationship between the standards of care, sort of like the process that's sort of authorized in terms of accessing care, and then that diagnosis the film is about, which is basically a mechanism of doing so. So one of the things that I interviewed a trans guy who's in the psych field who's doing some work with WPATH, with the organization around advocating for some of the changes around the DSM diagnosis. And what they want to do, which is mentioned in the film, is shift it over to a medical classification. So declassify it in terms of like psychiatric condition and reclassify it in terms of like medical. What that's supposed to do is give people an avenue to care. I think, to some degree, and the problem is that this person has this theory about brain differences, so we're going right back to sort of very essentialist notions of, where is it located in terms of like social versus biological. I did ask him some questions about, well, how would this apply cross-culturally then? Because sex and gender is different in different cultures. So what if it's all in the brain? Why isn't it the same in every culture? And there was no answer to that. But the fact is that, they're trying to place it in an endocrinological niche. So it's the idea that, like, the endocrinologist prescribes the hormones. That's generally what most people do, at least first, or that's what they do only, exclusively. I'm a little ambivalent about this myself, but I just want to let you know really what's going on, like the micropolitics of what's going on, not just the theory, which, this film does a really good job of sort of deconstructing a lot of the ideology around it. In terms of the world of public health, I'll just sort of very briefly say what I think my preferred strategy is, and that is in the world of public health, you actually can get around the whole gender identity diagnosis because most public health clinics understand various populations, and transgenders considered population from a health standpoint in terms of health disparities and people who are not getting care, people who are not able to access care and all the barriers to care. So what's going on, for example, at the Mazzoni clinic is that they use what's called an informed consent process. That's very different than this WPATH, sort of hoop jumping, first you do this, then you do that, then you have to live for however many months, and just all these very, sort of knotty problems in terms of gatekeeping. A informed consent process has nothing to do with gatekeeping. It's basically predicated on establishing the ability for somebody to be able to cognitively and coherently consent to the treatment that's being prescribed in the medical setting. So the idea is that as long as the person understands the risks and as long as the person is capable of consenting to that, that they can access the care. And to me, I'd like to see all medical doctors should have used that process. And the other thing that Mazzoni's doing is they're basically using a very vague, nebulous medical diagnostic term, if they need it at all, for insurance billing, and that's just, I think it's something like endocrine imbalanced NOS, which means not otherwise specified. So it's a very in some ways it's a very non-stigmatizing sort of way of just saying, anybody's got this sort of like imbalance and you can rebalance it with a little bit of hormones here and there. It even gives people some flexibility because if the medical provider is talking to a genderqueer person who wants like what's considered maybe half a standard dose of testosterone, that's fine. There's no real like you have to take this much, you have to take it on this schedule and for this amount of time. So I think there's some push here towards not only going, and Dean sort of said there are still dangers around medicalization because that casts a long shadow on people who don't access, any kind of medical care, who don't want to change their bodies, who still are gender variant or gender nonconforming. But I think that, making it a sort of informed consent process as opposed to saying, here's a label, here's a diagnosis that we have to sort of slap on people, and seeing it in terms of the health disparities model, in terms of like accessing care and barriers to care, really goes a long way to sort of depathologizing transgender-related care in general.
Yeah, you kind of took everything I was going to say. No, that's cool. No, yeah, I think that's the big thing is like kind of like, yes, like a medical, making it a medical thing would be like, yeah, I can get my insurance to cover my hormones, and I can get insurance to cover surgery and things like that. And like kind of promoting a kind of standard of care where trans folks are going to the doctor regularly in general, and I think that a lot of times people are like, okay, I'm going to go to the doctor and say what they need to hear so I can get what I need in advance and never really maintain my health. And I think that kind of sets up a precedent for that, like, I can actually like, maintain and make sure that I'm okay. Like, and after I get my hormones, do my, check my levels regularly and things like that. But then the bigger all-over question is that like trans folks in general don't access medical care for a plethora of different reasons. Mm-hmm. And so like I think the conversation becomes bigger because like just making it a medical thing is just not enough because then we're still not talking about why people don't access medical care in general. Mm-hmm. And I think especially trans folks of color definitely get disproportionately disenfranchised by that because historically there are different reasons why like brown folks don't go to the doctor. Be it I just can't afford to go to the doctor. Be it my family says we don't trust doctors because historically things like Tuskegee, like things like root really deep, and that's something that people don't shape generations later. And so it's this conversation of making sure that people are actually accessing medical care and that they are able to, more than insurance, and because even with folks who have insurance, people are still not going to the doctor. So what is that really about? And yeah, just kind of going off of like Mazzoni, like Philadelphia is really lucky, and there's a lot of trans folks in Philadelphia because of Mazzoni, because they have informed consent. And it's something where, you know, that's why I came to Philadelphia. I mean, you know, and I think a lot of people do for that reason where, you know, you don't have to, essentially you go and they want you to check in with a therapist just to make sure that you have a support system because hormones change your brain. So, you know, you want to make sure that you're kind of thinking all the way through, and that's not by no means saying like you need to go to a therapist because you need to have therapy because you have some problem. Just to make sure you have a support system and kind of go from there. You get like 3 sessions and then you're able to get hormones and informed consent. But even that, like paying out of pocket for hormones, like hormones are really expensive. So even if you have this, you know, access to care, like you might not be able to afford to go to the doctor regularly and pay for your hormones. It's like one or the other. And like some people, you know, what about folks who are gender variant or gender queer who don't want to take hormones, but like they still need to have appropriate medical care. And there's like all these cracks where people are falling through because it's just not enough. There has to be a further conversation.
But I think something you were talking about with, as like they're changing the DSM and trying to figure out like where to locate, kind of, it seems more like on the body and like where it's kind of where to locate this. But with this kind of change, what about, somebody in the movie talked about gender perception dysphoria, and so as like a location of the diagnosis changes, like is there any possibility for this stigma to change that surrounds, like with what that's associated with GID?
I mean, I think that the comment in the movie is basically saying, let's turn the mirror back around.
Right.
You know, it's like, so we're being sort of like micro observed as pathological individuals. Let's turn the mirror back around in society and see what kind of society actually does that. I don't see there's a lot of, besides like trans activism and trans theory and, you know, a lot of politics, I don't really see that that's going to be happening all that much in the medical institutions that we deal with. At the same time, you know, I think it's I don't know where I'm going with this. So as you said, I do think it's important, and maybe Q was sort of bordering on talking about this, where, you know, even if there is some medical care there, even if people, you know, all the various reasons they don't go, but even if they, let's say they do go, doctors still, you know, there's 2 pieces to this care if you're accessing medical, and that is there's a science piece, there's the actual therapies, et cetera, but there's also the cultural competency piece, which has to do with understanding people, and particularly on their own terms. So I think, you know, one of the things to talk about in terms of Mazzoni as a model and public health as a model is a harm reduction model, which has to do with like, basically one of the basic mantras of harm reduction is meeting people where they're at, accepting people on their own terms, so they're not going to be like judged according to all of these sort of societal standards. And the other thing about harm reduction is to see that, you know, you have to lower that threshold to care. If this major said in the movie, you know, the girls really want their hormones first, they don't want their HIV meds, then you access care at the point where somebody's willing to do so, and engaging them in care then can kind of take them along a continuum of care that otherwise wouldn't occur. So if you can get, and I'm saying girl because that's how some folks refer to themselves. So I'm using kind of the self-definition, self-determination language. So if some of the girls can get into care through, you know, getting their hormones, then perhaps you can engage further along that spectrum of care and caring for the whole body. I don't really know if that really gets at what you were saying directly, but it goes a ways in terms of the depathologization. If the doctors can take on sort of more of a harm reduction mentality and a harm reduction way of thinking, then they're not thinking, oh, is this person trans enough? Do they fit my gender stereotypes? They're really just thinking in terms of like, how can I get this person, you know, to a healthier place, but doing so that respects their integrity and their sort of, you know, it's kind of had an ethical relationship with that person that allows them to do so with the greatest amount of self-determination.
I think it's also like, it's tricky because I think it's tricky to have conversations solely about the body, because I think a lot of, you know, there is this kind of precedent of like, oh, I was born in the wrong body, so I need to like fix this. Where there's like, you know, and a couple people said in the movie, like, I am perfectly fine in the body that I am. I just happen to be, you know, I'm a man, I just happen to have this body. So I think it's also tricky, and we have to be careful about like focusing solely on the body and kind of fixing that. But I do think the harm reduction model is like the best way to go, and in forms of making sure that people are, because trans is an identity, right? It's not necessarily just like queer is an identity. It's something that that's your brain, that's how you feel about yourself. So it's not necessarily like there's something necessarily wrong with your body. And then those are folks who choose not to do anything with their bodies but choose to identify. So we have to be really careful what those conversations look like.
That reference to think about what Ben talked about, the sort of like trying to think about the sort of long-term ways of thinking about the health and concern of trans persons is really sort of important also too when we talk about the DSM, and what this document is, this umbrella term trying to think about is when we talk about these terms and these definitions and their inclusion in a document like the DSM, on the one hand we're basically talking about four things. Do we have the name right? Have we defined it right? Is it in the right place? Or should we get rid of it entirely? Those are your four options. So what's been preventing for us is should it be GID, or should it be gender dysphoria, or should it be some different name? If we pick the right name, which is probably going to be an impossible task, are we defining it right? And if you notice, if you look at the definitions of gender identity disorder and gender dysphoria and transsexualism before, which was in the DSM-IV, what changes a lot is not just the terms themselves, but a bit about the definitions and the qualifiers. And those actually where you get to the nitty-gritty and nuts and bolts about how much we're taking gender, stereotypical notions of gender, and trying to enforce those in a way that's not changing clinical perception, but actually putting it on the burden, if you will, of the person involved. If we're talking about where it's located, we saw that invoked by a few people in the documentary, and Ben talked about it, this idea then is that maybe then we need it in a different place in the DSM. And then lastly, do we get rid of it entirely? All of those are four different permutations that we could probably all talk about all day and try to think about the right solution. The important thing is that thing about thinking that our inclusion of things that speak to transgender health and definitions that speak to them shouldn't be just concerned with whether they identify correctly, or the right generic name, whether they provide the right services, or even provide the right insurance coverage, if you will. But rather, how much are those terms significant in the way that they provide not only comfort, but also entree into the clinic for transgender persons? So the real burden here isn't, do we get the name right, do we have the definition right, is it in the right place, should it be in there at all? The real burden is how do we make transgender people feel comfortable in the clinic in general? And that is the legacy of Tuskegee and of homosexuality and other terms that really carry with them a kind of suspicion towards the clinic on the part of the person. So when we talk about whether getting the term right, what we're trying to think about is not just how can we make transition better for transgender persons, or hormonal therapy, or psychiatric therapy, or what have you, but how can we make the clinic a safe space and a comfortable space? And part of that's terminological, part of that's definitional, if you will, part of that's also in a document like the DSM. But what it really speaks to is a large hurdle in terms of how can we think about the healthcare of the entire population, given the burden of terminology like this in a document like the DSM.
I have one more question, and then maybe we want to open it up to other people. You guys answered a lot of the questions you prepared anyway. So I just wondered if there was a distinct kind of generational gap between this Harry Benjamin medical ritual era of trans healthcare access that sort of necessitated surgical procedures, and this one of the people was talking about this post-Benjamin kind of notion of gender variance rather than sticking to binary in this, again, so-called trans community. And if maybe you could kind of speak on this perceived generational gap, where it comes from and where it's headed.
Well, I'll mention two things and then throw it to the both of them to talk more about it. Two things I'll mention are, one, the Harry Benjamin sort of philosophy on transsexual was very much this idea that there is a terminus that we're talking about. There's a place where we're getting, where you're fixed, where you're done, where you can pass, and that's the term that we're talking about. So trying to jettison that concept as though that there is a simple linear sort of like beginning, middle, and end. In fact, Benjamin is most famous for the fact that he really identified the different, what he calls stages of transsexualism, if you will. And that limited model, binary or not, is sort of something we're trying to move away with. The other thing I mentioned about Harry Benjamin is that one of his legacies, and Ben invoked this briefly, is the Harry Benjamin Society for Gender Dysphoria and how to approach gender identity disorder. And they've always had as their mission statement different ways to think about both to define and to treat transgender persons. They've always had in their mission statement, and I haven't read the most recent from yesterday, but it has been for many, many years, this idea that their goal is to create long-term personal comfort with the gender self, is what the goal of transgender healthcare should be. Doubling back to what I just said, I think that's half the goal, and the other goal is long-term personal comfort in the clinic itself. So trying to think about those as two sorts of things. The Benjamin model, to some degree, then, is once an antiquated throwback, but also something of a holdover that reminds us to a kind of, not just place we don't want to return to, but a kind of trajectory that can inform newer models or newer ways in which to revise older models.
I think the other, I know that Susan Stryker in the movie talked about how, you know, we have LGBT and like T was kind of thrown in there with these other like sexualities, and that it's become like an eroticized identity. I just kind of thought of, you know, because with that old model of this kind of like, you're going to transition and you're going to go from one to the other so that you can be straight and like kind of fade into society. And so I think with a younger generation of trans folks and like people exploring gender and like kind of pushing gender binaries and boundaries in general, like people are moving away from this thought of, you know, I'm going from here to here. Like personally, I feel like the word transition is really problematic, because then you're assuming that I'm going from one place and I want to get to another. Something in my personal experience, like I talk about, you know, my trans as whatever, and people are always like, oh, like if you wouldn't have told me you were trans, I would never know. And I'm like, yeah, that's what I'm telling you. Or like, you know, and it's this thing where I feel like people say it because they think it's affirming, and they're like, oh yeah, like you tricked the shit out of me. And in reality, it makes me feel more invisible, because then I'm walking through the world and I'm not being read by trans folks in my own community, and but I also know that I'm different than everybody else, because people are like, so what did you do when you were a little boy? I was like, well, I played with dolls because I was a little girl. So like talking about that, and I did a panel once, and a guy said to me, he came up to me afterwards, he's like, you know, I just really want to know why that offends you, because you reached your goal. And I said, but now you're assuming what my goal is. You're assuming that I like couldn't cut it as a female, so I wanted to be a man, and that just really wasn't about. And it was interesting because I didn't, until I was like on testosterone for a year and like really in the thick of it, is when I realized why I really started to transition. And it was really about my masculinity rather than like my essence of being a man or a woman. And it was something where like I felt like my masculinity as a woman wasn't being respected. And so it was something for me that needed to be at the forefront of my identity. I was always more comfortable with an effeminate masculinity than a masculine femininity. And you know, there's little nuances, but there's definitely a difference. And so for me, no matter how femme or flamboyant I can get, there's still an underlying masculinity, and I will always be referred to as he, and that's important to me. But that's not necessarily because I wanted to be a man. And so I think it's important that like we're having these conversations of like newer, younger folks are kind of pushing these things, because what society is saying, what is a man, what is a woman, like people just aren't sitting well with, you know. And you know, someone mentioned in the video like these diagnoses of like, oh, you did this as a kid, you did this, and you did this, and it's like everybody should be doing that and like questioning their gender in that way. It's just because you should be questioning things to figure out your identity. So I think that, you know, that old model is, you know, really just not sitting well with young folks in these days. And it's not about like rebelling, it's about like really taking agency in their own like self-awareness.
Well, I think there's a generational difference, yes, and I also think that this highly structured, linear, and reductionistic medical model never really fit all that many people anyways. And, you know, Sandy Stone, who you might want to read, wrote about this a good 20 years ago in the 1980s in response to a pretty transphobic cultural feminist text called The Transsexual Empire. And Sandy Stone's a trans woman who at the time transitioned within women's communities and was pretty much ostracized when they found out she was trans. And she wrote a piece called The Empire Strikes Back. And pretty much talks about like the way in which trans folks, just like Miss Major said, learned the narrative, learned the story, you know, dressed to the nines, did everything just right, you know, in fact, read the medical books, and went in and gave the doctors the very narrative that the doctors came up with in the first place. And, you know, she talks about the need for new narrative structures. She talks about narrative polyvocality. She talks about a sort of multiplicity of being, both in one person and also amongst all of us. And what I've seen is basically just a kind of visibilization of what was really a very complicated multiplicity of ways of being in the world, of ways of embodying. identity, and also of expressing that and talking about that and living that in the world. So I think what's happened is just that we've gotten to a point where it's part of our politics, it's part of the way that we talk, part of the way that we think, and part of the way that, I think the trans movements in general, especially in Western cultures, because I think we have some questions about how these things even apply in a sort of more global way. But I do think, I'll just say in the United States, where this word transgender actually emerged, initially it emerged as a term that countered the medical discourse, and it was specifically folks who didn't use medical technologies to change their bodies and still lived in a gender other than the one they were assigned at birth. And since then it's been sort of reappropriated by the medical establishment and sort of mobilized. And I think it's more complicated now because there's a lot of micropolitics that go on around the classificatory debates and around the way that medicine actually operates. And we have a for-profit insurance system in this country, which we could be talking about that because I think that's actually part of our problem in terms of medical access. But where I was going with this, so I just got lost all of a sudden. But I think that if you want to know about the micropolitics, there's a really good website by a woman named Kelly Winters, and if you go there, you can actually read year by year, detail by detail, what's been going on around the DSM diagnosis, because it's really much more complicated than any of us have really been able to articulate right now. And it really does matter because it affects people, it affects their lives, it affects the ways that people who have, like the woman in the film said, very little knowledge is a dangerous thing. It affects the ways that people think about trans folks in general. But it really does, it also affects, in terms of people who are accessing care, it differentially affects people. So I would argue actually that it does matter where a diagnosis, if there has to be one, is located. And I would argue that in terms of the way that medicine works in this country, in terms of the way that science works in this country, I think that we really need to think about the incremental micropolitics of how this plays out and not just say, oh, it's all bad, we shouldn't have any diet, or conversely, that it's just simply a disorder that needs to be recognized. I think there are people that have genuine distress in their bodies. I think they could live in any cultural context, perhaps, and they would. I sort of did that thought experiment with myself. I was like, well, what if I moved to San Francisco? What if everybody calls me he? What, I had embodiment issues. There's gender dysmorphia disorder for, there are people that just are uncomfortable in their bodies. Not necessarily saying they should be disordered, but the fact is that, we all sort of have body issues. And on the other hand, the politics of this diagnosis is much larger than any individual body. And while I think it's changing generationally, I still think that it's important that we pay attention to the details around how making a change in terms of how people access care and the mechanisms to do so, it has to be done so that people don't lose care. At the same time, it has to be done so that too many people aren't prevented from receiving care by having to conform to some sort of paradigm.
And another concern about that, the Gay and Lesbian Medical Association always puts out annually their list of top 10 health concerns for lesbians, gay men, and trans people. And always one of the ones for trans people is not just access to care and affordability of care, but trying to create an environment that makes it so people don't have to find care elsewhere in a place that's unsafe, whether that be hormonal treatments, silicone injections, hair removal, you name it, so to speak. So trying to think about how to not just make sure that we can pay for and provide the services in the clinic, but that people aren't trying, out of comfort, discomfort, or availability, getting the treatments they need from a place that's not safe at the same time. And the fact that the clinical community has a responsibility, and in fact the power with which to gatekeep those services in a safe, guarded, federally monitored sort of way is all the more heightened sort of responsibility that comes, even with semantic debates that seem like this.
Cool. So I guess we'll open it up. Just as a ground rule, because the last time we did this, 2 or 3 people kind of dominated the conversation. If you could not make ad hominem comments to other people, this should kind of be understood, but for sometimes you need to remind me that just no personal comments or attacks. Awesome.
Don't yuck my yum. It's my favorite.
So I'm a pediatric nurse practitioner. And so I know that kids are more comfortable coming out at younger ages, and there's more children with different, I'll just use quotes, gender dysmorphia, that are where their parents are more accepting, and preschools are more accepting of kids acting outside of gender norms. But as a pediatric nurse practitioner, what are things that you would have wished someone would have said to you, or things, it's tricky because of confidentiality, and it's hard to steer a 5-year-old towards resources, but even like in the adolescent years, like what are some suggestions you would have for me in terms of when I'm sitting down, just one-on-one with a teenager or someone who's like even 10 or something to help them?
Well, I think it was said in the movie, I think Dean Spade said it really well about this kind of thing. I spot a lot of young people are kind of talked to as you don't really know what you're talking about. You can't be sure of anything about your identity, which is just not true. You have a sense of your gender at 3 or 4. And so to be able to to talk to a young person and give them agency and self-identification, I think is really important. I mean, I run a trans youth group, and I've got kids who are 14, 15, and they're so sure of their identity, and I've just never questioned it ever. It's not just kind of oh, you're playing with something. It's just oh no, that's a boy and that's a girl, in that kind of way. And then there's that's nothing, they are just in between. So I think that's a really big thing. I think the other thing is, I remember I was working with some med students who were psychiatrists, and this one woman had a little girl who came in, and and the mom was oh, she likes to play with trucks, and she has this tool belt and she won't let it go. And the woman who was the med student was well, why don't you do something that's girl time bonding? Why don't you paint each other's nails or something? And just said something that was very gendered, and the little girl freaked out, and she was she freaked out, and just they never came back, and she was saying, gosh, how could I think to put something so gendered to, as a solution? And I think it just kind of staying really gender neutral with young folks, and let them determine which side they want to go.
Right, but how do you start that? For me, so it's a medical context, so you're coming for, because you have a heart disorder, so I'm more acute, but even if I was primary care, but what would you say to start, I know in your training it's okay, so we had sex with boys or girls, or this or that, but I don't feel that's really a way to start a conversation. Are you would you say are you comfortable with yourself? How would you start a conversation to have someone feel comfortable to talk to you about something that they might not feel comfortable talking about to anyone else?
I feel gender neutral language, and also because having sex with boys or girls, that's
right.
already,
it doesn't work.
Yeah, right.
Yeah.
So who do you have sex with? Or
open-ended
more
questions.
Open-ended.
I mean, it's just there's a lot of techniques you can use, to sort of not put the answer in the question.
Yeah.
I mean, it can be pretty simple when you start to think about it. The more that you allow that person to self-define and self-determine, and the less you project onto them, even unwittingly, I mean, it just becomes better care in general. I mean, I have so many questions because it just gets very convoluted when you start talking about the intricacies of care for kids, because
right.
they're not necessarily there for gender reasons anyways. If the parents are starting to make it an issue, then that's the parent's problem. If you start supporting that, then that becomes the kid's problem, because the parents are having a problem, then you're having a problem because you're supporting the parents having a problem. So, I would counsel the parents and say, there's a lot of latitude these days, and you're going to do a lot less damage to your kid if you let your kid decide what's right for them. And we need to restructure schools. We need to do all kinds of stuff in terms of allowing kids to be who they are on their own terms and when they decide. I mean, actually, there's sort of there's an assumption that if I could have had a choice at an earlier age, I would have taken it. I actually don't think I would have.